Okay, good morning, everyone. We will get started here. I'm Raj Dave from Harrisburg, Pennsylvania, from C3 Congress. It's a first webinar for American Bifurcation Club. I'm very proud and privileged to have an incredible group of interventionalists joining a North American effort on coronary bifurcation on behalf of Interventional Academy and C3 meeting. I've been hearing a tremendous enthusiasm about American Bifurcation Club for last 2 weeks. I've had multiple inquiries and people wanting to join the club, people also wanting to contribute to different webinars, cases, and the live meeting next year, as well as publications. So that's very exciting. Dr. Tanveer Rab, who is the current president of the American Bifurcation Club, I'm going to take it, turn it over to him in a second. I'd like to introduce him. He's a professor of medicine at Emory University. He's been a strong supporter of C3 Congress for many years and has a great interest in left main and bifurcation intervention. He's been doing a tremendous amount of work behind the scenes to get this effort going. So all the credit is due to him. And we're very, very happy to support Dr. Rab in every fashion we can with all the resources that we have for C3 and Academy. So without further ado, I am turning over to Dr. Rab to talk about the mission of the American Bifurcation Club, introduce the first panel and the founding members of the club, and then we'll discuss the cases.
Thank you very much, Raj. Raj has been very supportive, and for 16 years, Raj, Dave, and C3 have really almost exclusively hosted bifurcation meetings and hosted the European Bifurcation Club, as well as the let's see, I'm not sure, I'm not coming on. All right, can you see me, guys? Okay, Raj, okay. For some reason I cannot. All right. So, okay.
Yes, we see you, Tanveer.
Okay, all right, okay. So Raj has been instrumental in many ways in promoting bifurcation in the United States. And it's only natural that I, having a strong interest in the world of bifurcation, asked whether we could create a North American or American Bifurcation Club in the United States. So the American Bifurcation Club was created with like-minded colleagues who had an interest in coronary bifurcation interventions, were high-volume operators, and who were involved in the publications of bifurcation techniques and critical areas of research and trials in this field. So I was able to really be honored to gather a group of people, some of whom I hardly knew, and call them up and say, hey, I know you have an interest in this area. Would you be willing to join us in this effort? And so the group of people are really from various areas in this country. They do good work. They do a lot of volume. They publish and they're involved in newer techniques. And it's very important to get them on board to talk about cases. So this Bifurcation Club will be showing cases, talking about cases, teaching cases, and then with time creating our own North American approach to bifurcation and left main intervention that eventually contribute to research, but contributing papers and maybe even consensus documents. And their further interest is, of course, to create research and ideas and create registries and trials on behalf of the American Bifurcation Club. So without much ado, when I call out your name, please unmute yourself and open up your video screen to introduce yourself. So the first person I have is Shlofmitz from St. Francis in New York, a high volume operator and intensive contribution to research in coronary imaging plus coronary atherectomy procedures, coronary high and coronary interventional work, very complex stuff taking place at this hospital. So Richard, please introduce yourself.
Well, thank you for having me. I'm chairman of cardiology at St. Francis Hospital. And we are proud that we do a lot of complex calcified lesions, and we're one of the leading centers for interventional imaging and physiology, which we really feel goes right with calcified lesions. So I'm very happy to be here, excited to hear everybody's presentations.
So the next we have is Azeem Latib. Azeem, can you unmute yourself and share your video, please? and introduce yourself. That's Vlad. Is Azeem on?
I'm Good morning, everybody. Azeem Latib. I'm an interventional cardiologist from New York, the Montefiore Medical Center. Originally did my training in Milan, Italy. So I had the opportunity to join a lot of the Europeans as they worked on the European Bifurcation Club. Very passionate about bifurcations, and I'm glad to be joining you this morning.
And just as a footnote, as Azeem worked with Antonio Colombo for many years and was involved in the original classic crush technique, and a lot of papers, from bifurcation came out, co-authored by Azeem and Antonio Colombo in this area of work. Thank you, Azeem. Next is Dawn Abbott. Dawn, could you unmute yourself in video as well?
Yes, terrific. So I'm Dr. Dawn Abbott. I'm a professor of medicine at Brown. I'm at Rhode Island and Miriam hospitals. I do a high volume of interventions. I'm also very interested in research in the area of registries and administrative databases. Medical ed program director and CME programming and educations also. So very happy. Thank you for the invitation.
Thank you very much. Matt Price is on board. Matt, could you unmute yourself and also your video screen?
Hi there. I'm Matthew Price, interventional cardiologist at Scripps Clinic in La Jolla, California. Excited to be part of this adventure and to focus on some bifurcations. Thank you for inviting me.
Matt is a high volume complex PCI operator. I'm very glad to have him from Scripps Clinic. Thank you, Matt.
Thanks for having me.
We next have Vlad Dzavik from the University of Toronto. Vlad and I go back long ways in many areas of bifurcation research and co-authoring paper in the DK Crush trials. And Matt and Vlad, was a high volume enroller in DK Crush. So Vlad, please introduce yourself. Can't hear you, Vlad. You need to unmute yourself.
Sure, that'll work better. Hi, Vlad Dzavik. I'm an interventional cardiologist at the Petermont Cardiac Center at Toronto General Hospital in Toronto, Canada. And I, soon after Antonio and the group published the crush data, modified the technique, called it a balloon crush, so modified it for 6 French approach, and then had further modifications that led to the DK crush. And that's what I tend to do research with at this point. So I'm very happy. I'm passionate about bifurcations, left main bifurcations, very happy, and thank you for inviting me to the group.
Thank you. Kevin Croce from Brigham Women's was to join us, but he's on call this weekend. Unfortunately, he just called me and said he's taking care of a cardiac arrest victim, so he will join us a little bit later. Next up is Perwaiz Meraj. Perwaiz, please unmute yourself.
Good morning, everybody, and thank you for the invitation to be here. It's a pleasure to be here with these great group of people and talking about bifurcations, and hopefully we'll be able to continue the conversation with good cases, good discussion, good evidence, and happy to be here.
And Perwaiz is a footnote as a high volume chip operator doing very complex PCI at Northwell. Next up is Gautam. Gautam, you're already on board, so please introduce yourself.
Good morning. It's a great pleasure to be invited to be part of this group. My name is Gautam Kumar. I'm from Emory University as well, like Dr. Rab, and I function predominantly out of the VA, do some work out of some of the other Emory hospitals as well. A lot of interest in complex PCI, bifurcations, mechanical circulatory support over the years. It's I know a lot of the members of this group. It's a pleasure to be here, pleasure to work with friends again. Thank you.
Thank you, Gautam. Next is Babar Basir from Henry Ford Hospital. So Babar, unmute yourself, please.
Hi, Babar Basir from Henry Ford Hospital. Just want to thank everybody for including me. Thank Tanveer and Raj for having us today. It should be really nice cases. Looking forward to it. So
as a footnote, Babar is an early career cardiologist doing a lot of work in the shock area with the NCSI group and doing a lot of complex stuff. And he's also in charge of CHIP fellowship at Henry Ford. Next up is Arasi, a rising star from USC. Arasi, introduce yourself.
Hi, I'm Arasi Maran. I'm from the Medical University of South Carolina in Charleston. Pretty much interested in CTOs, complex PCI, and bifurcation PCI. I'm honored to be a part of this group. Thank you.
So very quickly, the aims of the American Bifurcation Club are really to educate and learn, not only from each other, but people in the country about coronary bifurcation technique and cases. And with time, that's the important thing, develop amongst ourselves our own North American approach to treatment of bifurcation interventions. And also, as I stated above, beforehand also, that we would generate amongst ourselves ideas for trials and registries as we move along. We plan to host after this monthly webinars, at least a 1 hour long session, probably on the last Wednesday of each month between 6 and 7 p.m. What we would call the American Bifurcation Club Bifurcation Hour, okay? So we'll choose from amongst our groups, and also we'll invite people from all over the country to contribute the cases of educative value. We'll choose them, invite you to be part of our webinar, and we will discuss it amongst ourselves. So this will be for all of you. This is an open forum. It's not into groups and societies. Everybody can participate. And so we'll announce that, I think, very soon, after we have the organizational details attached. So we'll do that primarily through social media and Twitter. And you know, remember, maybe once we fix a date, like a last Wednesday of the month for an hour between 6 and 7, just tune in. And so we will work through C3 Interventional Academy to create a spot for you to send your cases in, and then we as a group will choose some cases, and then say, come on board and present to us, and one of our members will be a discussant. Now today, we're also very honored to have Imad Sheiban from Italy. Imad and I also go back a long ways. Imad has been essential to the European Bifurcation Club, and has been also the Asian Bifurcation Clubs, has been a very important leader in contributing to bifurcation algorithms and bifurcation recommendations to the European Bifurcation Club. So from now, what we'll do we'll have 3 good cases to show. We will probably spend 20 to 25 minutes each, and we'll have a discussant. So in the order of business, Arasi, do you have to leave early? Did you just say that? Yeah, okay. So Dawn, would you mind if we flip you and Arasi around? Does that be okay with you?
Totally fine with me.
Okay, all right, thank you. So what we'll have is 3 good cases. So we'll start off the first case, which will be presented by Richard Shlofmitz. Each case will have a discussant. So what I would like to respect is that the discussant will be the primary mover for the cases and ask questions. So we'll leave it to the 2 of them, the presenter and the discussant. It'll be a stop and go presentation. We can chip in if we like, but I think the most important thing is to talk in a panel discussion, which will include, of course, our guest Imad Sheiban at the end. But if there's a specific question that really burning out there, then chip in and unmute yourself. But otherwise, we'll leave it to the presenter and the discussant. So Richard, you're on board. Please start your case. And Azeem, you are the discussant or the driver of this case. Richard?
Richard, you muted?
Was there a minute ago?
No, you're still muted, Richard. If you press your mute button.
There we go. Sorry.
Oh, there we go.
Now I got to get my screen back. Share. Sorry for the technical stuff. Just a second. Okay. Are we good now?
Yes.
Perfect. Sorry about that. So today I'm going to be talking about OCT-guided treatment of bifurcation lesions. And I believe that when you're doing any complex angioplasty, imaging is critical to success. With OCT, we use the acronym MLD Max, where we're looking at the morphology of the lesion, the length of the lesion to get normal to normal tissue, the diameter of the vessel. And then after we treat the vessel, we look to see that we have optimization to make sure we have no medial dissection, we have apposition and expansion greater than 90%. And using these 6 steps with co-registration guarantees you success. And there are many different ways to approach a bifurcation or an ostial lesion. And I've had this discussion with people that do things differently than I do. But my feeling is if I image both the main branch and the side branch with the technique that I use, and I document full expansion, then there's no criticism of that. So this is a case of a bifurcation lesion. And before I started doing angioplasty with imaging, if I looked at this lesion, I would say there was a significant lesion of the LAD proximal to the diagonal mid-LAD bifurcation. And ideally, I would say to myself, I really don't want to get involved in a bifurcation lesion here. I'm going to try to spot stent that, maybe a 3.0 or 3.25, 12 millimeter stent, post-dilate, go home and pat myself on the back. And that's something that I'm not sure if anyone else would approach it differently, but for those who approach it angiographically without imaging, whether it's IVUS or OCT, that's what it would look like to me. The mid-LAD doesn't look that bad angiographically. The diagonal doesn't look that bad after the bifurcation. So in this particular situation though, I imaged. And when I imaged the mid-LAD, we see that there's a calcified lesion at the bifurcation. If you look at the second cross-sectional panel, that's where the LAD on the left with the catheter in the LAD and the diagonal at the right, that's right at that bifurcation in the mid-LAD, you see calcium at least 180 degrees from 10 o'clock to 5 o'clock. And if you measure the MLA, it's 2.5, which angiographically, I wouldn't have predicted that. And I'll show you imaging into the diagonal subsequently. But once I saw this, I recognized that I couldn't take this as just a spot stent. With the mid-LAD being 2.5, I wouldn't want my inflow to be that much greater than my mid-LAD. So I then went and used OCT-guided placement. And what you do here is the cross-sectional image that you have is represented by that black dot, which is the lens. And depending upon what stent you use, your stent marker and where the stent comes off relation to that marker guides you as to where you place the stent exactly. And over here, my bifurcation is exactly at that lens marker. I'm not sure if that's where I would have put it if I was just going by angiography, but I go purely by co-registration with OCT. And here I have my stent across with the lens marker precisely where the cross-sectional was, and I have a balloon in the LAD diagonal system. And I inflate the stent, inflate the balloon, and now I do a pullback run in the diagonal branch. And the diagonal has an MLA 2.0 just distal to the LAD bifurcation. So the diagonal had significant stenosis distal to the bifurcation, where angiographically I wouldn't predict that. And you can see in these frames here, the lens marker of the diagonal is on the right, and you see the actually you see the catheter in the diagonal on the left, and the lens marker on the right of the LAD. So you see where the bifurcation comes in, and you see where the diagonal is just distal to that bifurcation. And what you do notice is that there are no struts in that diagonal there. But I then measure the length of stent from the proximal LAD to the diagonal across the mid-LAD branch. And I measure EEL, external elastic laminar, if I can, or lumen if I can't. And I go to the best tissue I can find. And if you look at the screens on the bottom left, the blue arrows, that marks the exact 23 millimeter length. So once I determine my landing zones, 23 millimeters for my proximal and distal, to put my stent in the best morphologic area, co-registration tells me precisely where I'm going to place that stent. So I know I'm not going to end up in an area which is maybe a thin cap atheroma or a calcified lesion where I might get a dissection. I also can measure the exact size of the vessel. I would say that 60% of the time people underestimate the size, and here I can get the exact size, and the bigger you get the lumen, the less chance I believe that you're going to have restenosis. So I place a 3.0 23 millimeter stent across the LAD diagonal. Then I recross into the LAD with another wire and do kissing balloons to post-optimization. And the beauty of OCT is that you can predict your optimization beforehand. If I know I have a 3.5 vessel proximally and a 2.75 distally, before I do my final imaging, I'm going to optimize every area I need to. I don't do POT, proximal optimization technique. I do COT, complete optimization technique. Proximal, mid, and distal, because I think the whole vessel is important to optimize, and OCT affords you that ability. Now, here's the critical part of this procedure, is that you must image in both branches, or else it's speculation that you have a great result. So I put OCT catheters both down the LAD and the diagonal, and I see the pullback from my diagonal. And what I love to see here is that you have almost 2 perfect circles at the diagonal with almost no metal overlap whatsoever. So it's.
Could I just ask for you to use your pointer to point to the images, just for the the colleagues and fellows who are here? Thank you.
Can you see that pointer? Is that?
Yeah, we can see that. That's great. Thank you.
I'm sorry, I would have done that sooner. I didn't realize. Okay, so here is my diagonal. Here's my OCT catheter. This is my wire. Here's the diagonal. So I start distally, and you see expansion. And here you see the diagonal coming in with the LAD, and this is the LAD wire. And you have both vessels completely open. And now we do a pullback from the LAD across the bifurcation. And this is the LAD, this is the diagonal, both, again, 2 complete circles, if you will. And you see that this is the key point here. This is where the mid-LAD, where I placed the stent right at the bifurcation. And here is the diagonal into the main LAD vessel. And you see there are no struts from the mid-LAD impeding on that bifurcation. And now here you have the proximal LAD. So going backwards from here, this is the LAD, this is the LAD distal to the bifurcation. This is at the bifurcation. And you see struts here, but nothing in the actual bifurcation. So this, again, is just an example of the pullback from the diagonal, where you see the diagonal vessel, the LAD vessel, 2 circles, and again, with the pullback from the LAD, you see the LAD in the diagonal. And if you don't show this confirmation, you really can't be sure that using this technique is safe. But if I show you have full expansion at the ostium, whether it's the left main, ostial circ, LAD, or any bifurcation, an OM or a diagonal, I always document that I have full expansion, because we know that's where the restenosis is, at the ostium there. So in this OCT guided bifurcation treatment, I believe you have enhanced visualization to determine the best strategy before. You need to do atherectomy if it's heavily calcified. Co-registration guided stent placement with no stent protrusion into the main branch. It's the miniest of mini crushes. And you optimize the main branch stent. And this is what I call precision angioplasty. Now, 3 years later, the patient came back, and this was the angiogram. They came back for atypical pain, and 3 years later, it was open. And in our lab, we know with OCT that things work. If we take a 3-dimensional view, the nurses always, well, let me just, in conclusion, ostial and bifurcation lesions are challenging to get great results. The OCT allows precise placements of the stents with co-registration. It gives you excellent pre-treatment strategy, calcium evaluation critically. You can get precise sizing to EEL to minimize overlap of metal, minimize overlap, edge dissection determination, and allows expansion of the parent and side branch, which is essential. And in our lab, we have a 3-dimensional view that we run to show that you have a great result. And I don't know if you've ever seen this, but the nurses always say, if my head can fit through that artery, you're not going to have any restenosis. Thank you.
Okay, so
Can I just continue to watch your head go through the artery for a sec, Rich, before asking any questions? That was great, Richard. Fantastic case. And I think really showing how we can use the tools we have now to optimize bifurcation PCI. I mean, I think one of the challenges that people often have are with really when you're trying to put a stent to nail the ostium and not push the carina away or not protrude into one of the branches. It can be very challenging, but I think you showed a great use of co-registration to do that. So I'm going to open it up for discussion to the panel and as well as the attendees. Matt?
Hey, Richard. Matthew Price here. Fantastic case. Always a pleasure to watch your OCT guided precision PCI. COP versus POT. I like that. I have to think about that for a little while. So I often, you mentioned the 3D. I think in that kind of case, do you ever use the 3D view, just stent only 3D view where you can see the outside of the art from the outside, right? It can rotate and make sure that you don't have any gaps and look at stent deformation and so forth.
Absolutely, the 3D view, and where you could subtract everything and just have your struts. It really lets you see where your wire is going in bifurcation lesion. I mean, there's so many, and with the new technology coming with OCT, it's to me so essential in order to do any kind of complex lesion.
My only other question would be, and I throw this back to Azeem, to Richard, is, or maybe you, Richard, are there certain angles of the bifurcation where you would lean away from trying to just land that main vessel stent? I mean, you showed, it was amazing. You nailed it. I mean, there's also different stents, right? As you mentioned, some stents are harder to nail exactly where you want them. So does the angulation, because we wouldn't want a T technique where you have a gap, for example, just at the ostium of that main vessel.
And that's the last thing you want is a gap. And that's why I always emphasize that I image after each one of these situations to prove where I was. So, you know, it's not just the angle, it's also the stents move sometimes, you know, and to your best ability, you see it jockeying back and forth. And what Ziad and Alan Jeremias and Jeff Moses work with me, and they're always criticizing everything I do. But what Ziad has taught me to do is we rapid pace when we do it, sort of like a TAVR. And we rapid pace to stop the stent from moving when it's juggling back and forth. So that's one technique to minimize movement and give a precise location. And the angles certainly make a difference. Angle, depending on the angle, it's difficult for any of us. And there you might use a different technique if the angle's not favorable.
So, Rich, maybe I'll ask, even from the panel, any thoughts on the technique you used? Because often, you know, the traditional teaching is stent from proximal main branch to distal main branch, and then do the side branch later. You kind of did this a little differently. You did the distal main branch, and then you went from proximal main branch to side branch. Is that a technique you use often, and why the choice of that technique in this case?
No, I agree with you. In this particular, the way I analyze it in my mind is what's going to be the easiest thing to cross over into. And it looked like a straight shot and the diagonal was huge. If the diagonal wasn't big, there's no way I would have done that. But if you saw the whole angiogram, the diagonal was equal size to the LAD and it was a straight shot. So I just customized it there, but I agree with you 100%.
Yeah, if anything, it looked like the ostium of the diagonal was probably even larger than the distal main branch. I mean, particularly afterwards, this was a great result. Imad, you know, the question still comes often, one stent versus two stents, and how to choose two stents. Richard chose his two stents here based on the imaging data. You've been really at the forefront of trying to give us criteria that we can use in complex bifurcations to choose which bifurcations would benefit from a two-stent. So how does this bifurcation fit into I think it's the dedication strategy?
No, yeah, that's a great question. I mean, it is all debate. But anyway, I think that we should fix some criteria in order to define what's complex and what's simple. And yet we do not have that. The only study was referring to is definition 1, but I think there are too many criteria to include every time. I mean, you are evaluating your bifurcation. I do not have a clear imaging on this bifurcation, this case, but I think you should every time consider the length of the lesion on side 1, what you consider side branch. I mean, if it is focal, I think every time you can try to go with provisional, with simple stenting, and just leave it. If you no damage on the side branch, you can leave it. This is what is, I would say, universally accepted now, is provisional stenting in simple bifurcation is the default strategy. However, in this case, I think it is, the technique was completely different, as you said, because he started from side. I mean, he did reverse provisional from diagonal to LAD, and he treated this mid LAD before. Actually, I'm concerned about about the gap that can leave between the two stents, because it is not always so easy to define exactly the bifurcation when you are implanting the stent on angio, because sometimes you have in different angle, the origin of side branch is not that much clear. So I think sometimes it could be difficult to land exactly at the ostium where you want to land with your stent. That is the main limitation of this kind of approach. In this case, I think it was easy because it was very clear, at least from here, I have seen that was very clear, no difficult anatomy there. But again, simple or complex, I think we still need to define what's complex and what's simple.
Thank you. I think it was a great example, and also probably shows why we need these bifurcation clubs to talk about this, because there's just so many different ways you can treat a bifurcation lesion. And I think, this case highlights it. You probably, if you had, I would have loved to have seen a poll in the beginning before you showed us what you did, to have polled all of us to see how people would have treated this. And I bet you it would have been very different. There would be, at least 3 or 4 different ways to have treated this. And I think even the audience would be very split. But that just highlights the fact that I think bifurcations are so dynamic, so interesting. Dawn, yeah, I think it's interesting concept of using imaging to maybe decide your strategy. There's data for that. There's some data also for IVUS. Is that what you do, or do you use FFR? Do you use physiology? Do you use just the angiography to try and make a decision about the strategy?
Yeah, like the comments I was going to make about this case, I try to avoid angiography alone. It is generally imaging is going to be superior for deciding on your stent diameter. So when I do use physiology, it tends to be in physiology alone, although in provisional, I think it is very acceptable physiology alone. In this case, I think OCT certainly gives you better definition. It would be my choice. Prior stents for sure, or new high-dose IVUS. You just have to be careful about undersizing if you're not used to OCT, because as Richard pointed out, it's sometimes really hard to see the media. And if you're going to use the lumen, you need to get into a relatively normal segment of the vessel to look at your reference. I agree in this case, I wasn't 100% convinced that the bifurcation needed to be complex or 2-stent. But I think maybe what drove the decision was that the diagonal appeared to be the dominant vessel. And I think had it been the opposite way around, a provisional approach would have been chosen for the severity of that side branch lesion, which again here was the LAD in this case. So it's a little bit of an interesting case. And I think the result will speak to the long-term durability, whatever strategy one chooses. And that's the important part, to really define what a successful stent endpoint is, so you can achieve that.
Azeem, can I make one comment about imaging? And I just wanted to just reinforce what Dawn said and Richard, is that particularly with complex bifurcation, with 2-stent strategies, the pod or the comp is so important to get a good proximal optimization, because you'll go down the rabbit hole if you don't have a good pot. Your wires will get behind stent struts. It can be a disaster. So I think if you're going to do a 2-stent strategy where you need to re-enter a side branch, imaging to make sure you really understand the size of the proximal reference vessel is essential.
I would add to say that the pot is important irrespective of what strategy you're using, because you could go abluminal with your rewiring in either a 2-stent or 1-stent procedure. So we have to remember that the stent is sized for the distal main branch if you're in fact stenting across the side branch, which case that was not the case, because the stent was left in the distal main branch. But if you're doing stenting from distal main vessel to proximal main vessel, that stent is in fact sized for the distal main vessel. So by definition, because of Murray's law or because of Fanet's adaptation of Murray's law to coronary artery disease, to bifurcations, by definition, that stent is going to be too small for the main vessel. And that ratio by Fanet was described as, so the diameter of the main vessel is this approximately 2/3 or 0.678 of the sum of the diameters of the daughters of the branches. So we know that that stent is going to be too small. And if you try to rewire the branch before you do a pot, without a pot, you may go abluminal and underneath the stent struts. And that's always going to be the case, whether it's a one stent technique or whether it's a two stent technique. I can also comment on this particular procedure as far as technique, but I'd just leave it at that point.
Yeah, absolutely. Well, I think, POTS has become a part of all of our daily practices. But I do think imaging and the way Rich shows it allows us to get even more information, particularly, in this case where, Rich, I think you only crossed over once through your stent struts. But, I like the fact that particularly with bifurcations, we concentrate a lot on the pot, but one of the areas that often we pay the price for is the ostium of either the side or main branch, where the bifurcation comes off, of not getting the best possible result there. Maybe, Perwaiz, I'll ask you, what's your preferred two-stent technique right now?
So it depends. And I think my comment was going to be, I think we have to all be careful, as you mentioned, had you polled everybody in the beginning, everyone had 6 different ways of doing this. And I think that's probably a good thing. It's probably not a bad thing, because we shouldn't get too dogmatic in how we approach every single bifurcation the same exact way, because every bifurcation is different and unique. The one that Rich showed was very unique in the sense that the bifurcation was essentially almost like you were treating a left main Circ LAD bifurcation in it, very much in essence, because you were treating very large vessels as a bifurcation. And in that particular technique, if you can approach it in a provisional way, as Imad and other folks are saying, that's probably the preferred technique. However, when you have 2 large vessels, it seems like the data suggests that the DK crush is probably your most effective technique, with 2 large daughter branch vessels as well as a main branch vessel. However, utilizing imaging the way Rich did it, you were able to do it in a way that you may have actually achieved an equivalent result, not having to do the DK crush technique. And I think so. I think getting too dogmatic in one way, I think I personally look at every single bifurcation differently and look at it uniquely and say, okay, what am I going to do in this particular case? Where's the disease? Image every single vessel. And I agree with Dawn. Personally, I use a lot of physiology for my side branches before I do a 2-stent strategy, because we all know that 2 stents are probably not better than 1 in general. So if we can get away with 1 stent and not have to use a second stent, it's probably in the best interest of the patient.
Great, thank you.
I would just add to that 1 stent is better than 2 in more simple bifurcations. I think in complex bifurcations, the DK crush studies have shown that that's not the case. And the studies that showed us that 1 stent is better than 2 were done with old 2 stent techniques that were done very imperfectly before what I would say perfection of the 2 stent technique that was the DK crush. And secondly, those studies were done primarily with 1st generation drug-eluting stents, so very thick strutted stents. And I think it's very different now. I think we need new studies. I think definition 2 was done primarily with newer stents, not 1st generation stents, and in very complex bifurcations, which those were, that showed a clear superiority of the 2 stent technique, not just DK crush, because actually that study was a strategy trial, definition 2, where the majority of patients, about 3/4 of the patients in the 2 stent technique had DK crush, but there were also culottes done, as well as TAP T-stents done in the 2 stent techniques. So I think that's important to remember.
Well, if I can ask, also Excel study which is not so old study, have been showing that provisional stenting is doing better than 2 stents when it's feasible. I agree with you. That is good only in simple bifurcation. In complex bifurcation, I totally agree that 2 stents are doing better. Whatever is the,
And also, I think, you know, to add to that, that's a great comment. To add to that, Annapurna Kinney just published the Excel bifurcation data, right? And most majority of those were done with non-optimized bifurcation techniques, I would say, when the 2 stent techniques were done.
Actually, yeah.
There were no DK crushes, I think, at all in Excel, for example.
Yeah, the old studies, yeah, I agree with you, yeah.
The techniques are not standardized in Excel, including when everybody did their own thing, particularly from small centers. So that is an issue. So, so everybody, if we can wrap this up within 5 minutes, because that half an hour will be up, we can go to the next case. So any final comments or points from Richard or Azeem or the rest of the group?
Just one quick question. Just looking at the angiogram, for those who don't image all the time, looking at the initial angiogram, if you recall.
Can you share that again, Richard? Or?
Yeah, can you show it to us again?
For those of you who don't image all the time, either on the panel or in the audience, if you were looking at that initial angiogram, how would you have approached that? Just to put a spot stent proximal to the bifurcation? Because even if you did physiology in both branches, physiology doesn't tell you anything about the inside of the vessel. It tells you where maybe a drop-off of a significant pressure drop-off is, but it doesn't tell you how to do it. So if you were just using angiography, would you have just spot stented proximal to the bifurcation?
Can you show it to us again?
Yeah, I think it'll be good to see it again.
So Richard raises this important point. A lot of places do not have imaging in this kind, but people still do bifurcations. So is it imaging king? Do we have to do this imaging? Is this very, very important, or really people should be doing optimal care in coronary intervention?
You see it up there now?
Yeah.
So very quickly, we've got a couple of minutes. Maybe
if I can make a comment in this case, I would actually strongly consider making the LAD the side branch and do a provisional technique here. Yeah, I've done that and very successfully. And as long as you image after your KISS, after you've optimized everything and you have no significant dissection, that would, I think, work out fine in this particular case, because I agree this is a very important diagonal. If we go by recent CT data, it's a diagonal that probably supplies at least 10% of the myocardium. It's 70 millimeters in length. It's the major big branching diagonal. So it is important, and you could argue that you choose that as the main branch in this case for the bifurcation technique.
Okay, so Vlad, you're going to go from LAD to diagonal provisional towards the LAD. Just very quickly, because we want to wrap this up. Anybody else would have chosen a different strategy just based on the angiography? Imad?
Yeah, I think I'll do the same. I mean, as I see the angio from here, I think it could be working with provisional, reverse provisional, let's say, from LAD to diagonal, because diagonal is bigger, much bigger than LAD. So it could work.
Right. Matt?
Yeah, I'm trying to erase the last 30 minutes of my life. So what I would have done just looking at this is I'm assuming we're treating that LAD lesion is proximal to the bifurcation. I would have done a prox LAD into mid LAD directed by OCT to make sure I size my stent distally and proximally correctly. And then I would have assessed the ostium of the diagonal with FFR or some other technology. So provisional stent, LAD main branch.
Okay, great. Arasi, you've been very quiet, so maybe a quick comment from you, and then we'll answer one of the questions in the Q&A and move on.
So I think my strategy would have been similar. I would have done provisional stenting, mid LAD, prox to mid LAD, and maybe FFR, the diagonal after the LAD stent, and then decide on the second stent.
So let's wrap up this case and let Arasi load up. In the meantime, there's a question from an audience. What about the contrast load, Richard, in this case?
I don't recall the contrast level, but what I could tell you is that when I use imaging, I use much less contrast than the average person doing an angiogram, because I take 3 angiograms, 2 on the left, 1 on the right before, and then I use my OCT to image, and I don't do a post shot typically. I'll just use my OCT image. So I use less contrast than an average angiographer.
Thank you. Can you unshare so that Arasi can go on? Thank you, Richard, very much.
All right. Good morning, everyone. And it's a great start off to this session. So I'll be talking about DK crush, but I'm going to hopefully have time to ask questions throughout and hopefully have a more interactive session. So my patient...
This minute, Arasi. So the discussant in this case is Vlad Dzavik. So Vlad, come on board. And yes, stopping and go and polling would be very nice for the group as we move along. Okay, and you have half an hour. Okay.
Sounds good. So this is a 72-year-old male with known AAA. He had a 5.6 centimeter abdominal aortic aneurysm, came in with unstable angina, history of coronary artery disease in 2017. So since he came to the ER with chest pain, they immediately did a CT triple rule out to make sure his aneurysm hadn't dissected, which basically showed a stable 5.1 centimeter aneurysm. There was a moderate left main stenosis, multifocal severe LAD stenosis, moderate stenosis with ramus, and severe ostial circumflex stenosis, and multifocal distal RCA stenosis. Several comorbidities in this patient, hemoglobin A1C of 6.2, obesity with a BMI of 39, stage 2 chronic renal insufficiency, liver disease with thrombocytopenia, abdominal and thoracic aortic aneurysm, and extremely frail. He can get up, walk to his bathroom with help, but pretty frail overall. So this is his diagnostic angiogram. You can see a little semblance of the left main LAD stenosis coming up. And then moving on to a spider shot, you can see the stenosis here, ostial LAD, ramus, and involvement of the circumflex too, and distal LAD stenosis. And the RCA was pretty okay, but the distal RCA has some mild to moderate disease. So with this, anyone, what would be your next steps?
Vlad, you have to take the lead.
Yeah. So, I mean, the question was already asked, so.
Sorry.
so yes. I won't comment at this point, but I'll ask the same question of the panel.
Can you just go back and show the angio again, please?
Yeah.
This is Dawn. I do agree that in the absence of an emergent procedure, a complex patient with complex anatomy, the heart team, at least in theory, is certainly recommended. Just going through the exercise of assessing the anatomic with syntax or a simpler score, and patient complexity potentially with something like STS.
So I think Don most would agree with that, perhaps, unless there are some who disagree with that strategic approach. But what would your discussion be in that heart team meeting in terms of what to do?
By having have a discussion.
You're breaking up, Dawn. I'm sorry.
Oh, okay. I think if you're going to embark on a discussion with a surgeon, you need to have some, it depends if you're coming at it, whether there's they're going to be a surgical turn down. That may be a simple question. Otherwise, I think it helps to come with some data, syntax to STS to put some perspectives. Of course, individual patients don't always follow those rules, but it's good to not go into a discussion without a sense of what, your sense of the case. And again, I think going in, the thought is maybe the patient is not a surgical candidate.
Well, let's imagine that he's not.
Yeah.
And I don't think I personally don't think he's a great surgical candidate. And I think the LAD is a poor surgical vessel. But this is a bifurcation meeting. So what would your thoughts be about if we were to go with a percutaneous revascularization approach here?
Yeah, I mean, I think here you have a trifurcation. So you need to prepare for that. We can discuss approach. I think radial access is usually generally with a 7 or 7.5 guide. Imaging, multiple wires. Again, once I get a more clear view of the ramus, generally trying to maximum of 2 stents in a tris post dilation.
I have a question about intermediate. What about, I don't see any the involvement of intermediate branch.
It was quite severely diseased, I think. Can we see the left coronary again, please? The spider view. Go back a slide. I think it was the spider view that showed it best, not this one.
Sorry, it's a continuous movie, so it has to play all through.
Oh, okay.
There you go.
Oh, but you can go back a slide. Oh, there, okay.
Yeah, okay. Mm-hmm.
Pretty tight lesion, I think.
Yeah.
We pretty much, I mean, I think Don pretty much predicted what was happening. So we stopped. It was a stable patient. He did not have enzymes, so it was unstable angina. So we calculated the syntax score, syntax 1 and 2. You can see the percentages for PCI and CABG. And with syntax 2, CABG or PCI was pretty much similar. But then we did the STS score, which is what made the decision easier for us, with length of prolonged ventilation being around 22%, is morbidity and mortality of 34%, length of stay and long length of stay being this high, and with his thrombocytopenia. And if you remember, I talked about the frailty index. He was pretty frail. With all that, they didn't think he would be a good CABG candidate because he's not going to be able to do rehab as efficiently. So with that, we decided to...
One other thing, Arasi, what is life expectancy with all this? Is it more than a year, 2 years? Do you think with the liver dysfunction is going to survive longer than a year? I mean,
he had thrombocytopenia. Otherwise, the synthetic function of the liver was good. So we did expect a life expectancy of more than a year. So with that, we decided to go forward for high-risk PCI. Do we want to stop now and talk about procedural details?
Yes.
So one thing, Babar, Basir, if you high volume Henry-Ford Hospital, a lot of support devices. Make your comments here, known.
Well, it's interesting. I mean, I think if one is to seek out going for a trifurcation, bifurcation in this patient, what is the decision making in hemodynamic support? Unfortunately, as of right now, we haven't discussed any of the hemodynamics. So I think that would probably be the first thing that I would personally do in trying to help make that decision. The patient does have an open right coronary artery. If the patient's hemodynamics are okay, I think that you can probably, reasonably do this without hemodynamic support. However, if the hemodynamics are not okay, if you are really thinking about potentially doing a 3-stent strategy in this trifurcation, and you feel that those other vessels will be in significant jeopardy, or that ischemia will cause significant myocardial stunning, then clearly that would possibly be an option as well.
So what support strategy would you choose in this case?
Again, we would have to get a little bit more information about the patient's femoral angiogram, axillary angiogram, things like that. But I think based on the hemodynamics and, that would kind of guide that decision making. So we know from the PROTECT 2 trial, the patients got more revascularization and more atherectomy with Impella use. If those things are being considered, that may be one strategy. However, the short-term strategy was not different in that trial. So in someone with severe peripheral arterial disease and where a balloon pump may provide them enough support, that would also be a potential option as well.
So he has a 5.6 centimeter abdominal aortic aneurysm. You'd still be okay with all of that?
I personally would be. I don't know if that is going to really change it. You're going to be short-term management here just in the cath lab. I mean, I would be leaning towards an Impella anyway if in this scenario. But again, I don't even know the hemodynamics. I can't answer that question.
Arasi, can we ask what was the ejection fraction? I forget, you may have mentioned.
Ejection fraction was between 45 to 50%. In the initial diagnostic cath, his LV-EDP was about 25, but we had time between the initial cath and the PCI. He was medically managed in hospital with nitrates and diuresis. So I will be talking about a little bit more as we proceed.
And Arasi, do you recall what the systemic blood pressure was at the time?
Oh, he was, blood pressures were elevated. It was in the 140s, 160s.
I think that gives us all enough confidence that, we don't likely need hemodynamic support here. So I think that's a good discussion point, but I think we can move on.
So how would you proceed then with the procedure, with the, what are your thoughts, concerns about the technical aspects of this?
Absolutely. So I think that mid LAD is severely stenosed. I think personally, I would wire all three branches. We use a lot of IVUS imaging at Henry Ford. I would personally IVUS into the ramus and the circ. I think that my initial approach would be to stent the mid LAD and then stent provisionally from the LAD back into the left main, given the size of those vessels, recross with final kisses into both. However, if there was very significant disease in both of those branches, and we were actually thinking about having to treat each of those branches, I would do a double DK crush into the ramus, into the circ, and then crush it with the final LAD to left main stent. That would be my approach.
Okay.
Imad, how would you treat this? You're muted. Imad, can you hear me? You're muted, please. Thank you.
Sorry.
You're good now.
Just to point out, Imad had his largest series publication on treatment of trifurcation, so he can give us his opinion from that paper.
You actually, in what I'll do in this case, you mean?
Yes.
Yeah. What I'll do, at least from what I've seen from here, I'll go for stenting from wiring, of course, all three branches, stenting from left main to LAD, and then I'll treat intermediate with only balloon, better if drug-eluting balloon. If needed, to add a second stent, only if needed, I'll go with TAP. Actually, because circumflex doesn't seem that big vessel, and it's mildly involved in the lesion. I mean, the ostium is not that much bad. I mean,
so you would do this as a provisional approach. You would balloon the intermediate. You would crossover stent, leave both wires in,
exactly.
And probably rewire, do a drug-eluting balloon into the intermediate, which is a large, huge vessel, That's essentially all the lateral territory is that intermediate. And if need be, do a provisional stent, presumably
to
something
intermediate
like a
by tap technique, yeah.
Yeah, okay. Dawn, anything different?
I would, there appears to be calcification in the vessel, and I just want to know if any plaque modification at ramus disease extent, because to me it looks like it's probably a longer lesion than it looks like. And if so, then use a 2-stent strategy with a wire protection of the AV groove circ here, which is important, but less diseased and better angulation for provisional approach. And then stent the ramus first with probably a mini crush with the LED back to the left main with appropriate stent selection, because it looks like even here there's some discordance in size that's likely to be at least 1 millimeter, which some these may not. I think if you go far enough, you may get more of a 1-to-1.
Don, do you mean mini crush or DK crush?
I would just a mini crush here. I mean, you could also with the.
So I just want to comment on that, because to me, a mini crush is no different than the original crush. The only thing that's different is the number of struts protruding into the main vessel. So if you just do, if what you mean by mini crush is you crush and then you stent before you recross the vessel, that's what I think of as a mini crush as opposed to a DK crush. Then you'll never open the struts of the side branch adequately, because you're always crossing through 3 strut layers, and depending on where in the cells, you will never get that perfect opening. So in my mind, once you crush, that you have to recross and dilate those struts before you deploy the main vessel stent. So I'm not sure if that's what you meant by mini crush, or if it was the original kind of crush, but in a mini way that you meant.
Yeah, I mean, sometimes I still DK crush if I'm imaging and I make sure I've expanded, but point there, I would not try to do minimal protrusion, minimal crush in that technique. It depends what this angle is, but imaging will.
Yeah.
Well, actually today, I mean, if you are doing crush, I think you have to optimize crush, and optimizing crush without DK crush, it is too much difficult.
It's not possible. Yeah. So can I also ask a question? You obviously have to deal with the left main first, at least to ensure that you have it adequately opened. But what about the distal LAD? What would people do with the distal LAD?
Yeah, hi, it's Matthew. I would say first, I would, just stepping back for the bifurcation, I think less is more. We may be very happy with ourselves with the trifurcation stenting, but I think maybe pre-dilate the ramus, 2 wires, and just a provisional stent across the left main, then do a tap. And it'll be done very quick, beautiful result. So Imad, I agree with your points. I would image this not only to assess the distal LAD as well, but to understand the size of that left main, because I think it's even the prox LAD is huge, and that may impact upon stent choice, and to make sure that you have good lesion preparation. You're going to end up, I would treat that LAD, you're going to end up using a long stent, maybe a 225 stent, against imaging is important, but also to see how much calcium is there. If there's a lot of calcium, you may even think about, I do see a lot of calcium in that angiogram. This might be actually nice. In the US, off-label shockwave with the 2.5 balloon, or in Europe, you have that to make your life quick and easy. The EF is a decent 45%. That's my thoughts. Keep it easy. Maybe to quit one long stent to the distal LAD, mid to distal LAD, another big stent in the left main, tap the ramus if needed.
Yeah, I would agree. Simple is probably the best approach, and to use this as a provisional. This is where imaging comes very useful, because if it indeed it is a circumferential or near circumferential calcification, that's where shockwave lithotripsy obviously works the best. It doesn't work if you have just a quadrant of calcium. Doesn't work so well. So I think that would be important to image this. And this is going to be a 6 millimeter LAD, I suspect. It's at least a 5 millimeter LAD.
Yeah,
so I agree that your choice of stents is also going to be dictated by that to some extent.
absolutely.
You know, frankly, I don't know how you approach a left main case without imaging. I mean, you just have no idea what the size is. And when you're talking about provisional, it gives you tremendous information about the branches you're looking at. You're shocked so many times when you see that the origin of a side branch, or ramus or circ, may not be diffusely diseased, or it could be circumferential calcium. And if you went in there and did a ballooning on a circumferential lesion, you're going to dissect it. And you know, you're not going to get a great result. So it changes your strategy. There's no downside of you having information. Information can only help you. If you're doing left main stenting, how you do that without imaging, I don't know.
Yeah, I agree. So Arasi, we've kibitzed a lot here. Can you actually show us what you did?
But interesting, I agree with all the points, and we talked about all this. So we decided to proceed for high-risk PCI. So this was my plan. Okay, it's an unprotected left main, Medina 111, mildly depressed ejection fraction. He had elevated LVEDP during the diagnostic, but has been on medical therapy. And we do have the problem of this aortic aneurysm. So the points to think about is access. We could not get right radial access. He had a non-pulsatile right radial artery, and ulnar artery was really small. So we had to go femoral, and we had to think about mechanical support, again, as we had discussed here too. And a need for atherectomy also. And usually if I'm going to do unprotected left main and atherectomy, then as the steps increases, I like to have support. And the final thought is what kind of bifurcation strategy to choose. So we discussed pretty much all of the above.
I guess I might add one more thing, and that would be duration of dual antiplatelet therapy, because this patient clearly is going to need surgery for that aneurysm very soon. Like it's 5.6 centimeters.
Yes.
That's a fairly urgent procedure. So that's probably a factor as well. Your duration of dual antiplatelet therapy.
Agreed. So initially I thought we'll reattempt the right radial and get a 6-7 French slender guide and get a 7 French guide, so that I have a little bit more options on bifurcation strategy. Check the LVEDP. If the EDP was elevated, then think about mechanical support. And looking at the images, the size discrepancy between the left main and the circumflex. So I wanted to go with a DK crush strategy. This was my plan.
So was that for the circumflex or the intermediate?
For the circumflex. I wanted to, I was the intermediate and see and just go with balloon. I, in general, prefer bifurcation strategy to trifurcation stenting. Less is more. This patient, again, if we are going to stop dual antiplatelet therapy, etc., I don't want 3 stents sitting in the left main, distal left main. So I wanted to go with the less is more kind of a strategy here. So right radial artery was now non-pulsatile. So we switched to 7 French. The aorta was extremely tortuous. So we decided to put a long sheath, and every 100 centimeter guide could not even reach my left main ostium. It was all hubbed. I don't have longer guides. So we had to switch to a 8 French 45 centimeter sheath, and then use a 6 French EBU 4.0. Even that was pretty difficult. And these are the steps of DK crush. We'll go through it. And this is literally, I was at the ostium of the left main, and I had to float a wire into a coronary to kind of get that eventually, get the guide to sit for me. So it was extremely tortuous and extremely challenging just to get to this portion. And at this point, the LVEDP was 12. So I decided against mechanical support. So my strategy was wire all 3 branches, IVUS, and then go. So
did you consider just a 7 guide, just because the vessels are so long, they get the post dilation balloons in a 6. Sometimes it's just so much easier to have a little more space.
Yeah, when I work radially, I generally go 6 French, maybe sometimes 7, but I don't usually have an issue getting 2 balloons or even a balloon and a stent through 6 French. But absolutely, if you can go 7 French, and you're femoral already, but I think your issue was you couldn't get a guide, 7 French guide that reached. That was the problem, right?
Yes, that was the problem. It was impossible to navigate the tortuosity. It literally felt like I went from South Carolina to San Francisco back to New York like that. It was like so we finally, thanks to the 8 French long sheath, we were able to get at least a 6 French somewhere in close to the coronary so that I can float a wire in.
Arasi, it's Matthew. I'm exhausted and you haven't even wired the left main yet. So this is going to be a challenging case. I hate to be an armchair quarterback. I wasn't there. Any thoughts of left radial? Is that something maybe in your lab you don't like to do? Just throwing it out there.
Yes, his BMI was 39 and it would have just broke my back. We did think about that. It's just it's just too intense, and
Understood. That explains a lot. Thank you.
Yeah. I think the other thing is we don't use it much, but on certain occasion, brachial may make your life easier.
Well, Dawn, actually, that's a good point. And I know there's some people, I think maybe some people from Europe in the line here. You could go ulnar. I don't go ulnar because of issues with hematoma and the median nerve. But there is some data. I mean, some radialists in Europe will choose the ulnar artery in situations like this. So that would have been.
I would hesitate to do that when there's no palpable or Doppler detected radial pulse. But I know the real radial purists probably still wouldn't have a problem with that. I'm a radial guy, 80%, but.
Vlad, I agree with you. I would not have gone ulnar here. I'm just throwing it out there that some aggressive radialists would proceed with ulnar.
Even in the absence of a radial pulse.
We need, gentlemen, we need to keep track of time.
Sorry, Rob.
We need to have 10 more minutes for this case.
Good.
Don has to go next. Thank you.
Okay, so we wired all 3 branches. I apologize in advance. I don't have the IVUS images, but I promise you I IVUSed all 3 branches. And when on IVUSing, you can see the IVUS catheter in this in the LAD right now. The ostium of the circ was severely stenosed. Even though angiographically it did not look like there was much disease, the ostium of the circumflex was severely diseased. So that kind of reiterated my strategy of DK crush a little bit more. This is the IVUS. I chose to, based on IVUS imaging, treat the distal LAD with a 2538 drug-eluting stent. I used a Resolute Onyx so that in case he can only do 30 days of DAPT, he would still be able to. But in left main,
quick question. Were you able to, do you have any difficulty passing the IVUS with 3 wires to a French guide?
Yes, that's an important point. He actually had a little bit of a calcium, but not 360 or anything of that sort. The vessels were actually, the MLAs were small, but it was all fibrofatty plaque with specks of calcium. So that's why I decided not to go with atherectomy also. So IVUS really changed the game in this case. If not for that, if I had to go angiographically, I would have probably done atherectomy of sorts, but I didn't have to, thanks to the IVUS imaging. So then we stented it. In this, I'm placing my side branch stent with protrusion into the left main. That was a 3012 drug-eluting stent. You can see the balloon in the distal LAD so that I can bring it back for crushing. And this is the crush of the side branch stent right here with the 2520 NC balloon. And then I rewired with a Choice PT wire. And here's my first case. The balloons were 3020 NC in the LAD and a 2520 in the circumflex. Any thoughts or discussion for wire choices for recrossing?
Yeah,
I just about your 2.5 balloon for your first crush. You want to talk about how you size that balloon?
So I had the balloon from the previous, from the LAD stent, and I actually used it. I know I should have used a bigger balloon, a 1-to-1 size, but I thought that should be okay to start with. I agree. I should have sized it 1-to-1 and gone with a 4.0 balloon.
So did you then do this crush and then immediately went to rewire?
Yes.
Okay, so I have to agree that that's probably, I would have chosen a bigger balloon for the reason that if you crush with the balloon that size for the distal main branch, your stent actually isn't going to be completely crushed in the main. So you could potentially go in all kinds of ways, and you need to have that. What I do now more commonly is actually a pot crush, or at least follow the crush that you did with a pot with a balloon size for the main vessel before I recross. And that's the reason that if you just crush with that 3.0 stent, which I'm even surprised that the 3.0 stent was large enough for the LAD, because that looks like a sizable LAD, but I would follow that with a pot or do a pot crush immediately so that I have a short balloon. And this is new. I appreciate that I would have a balloon sized for the left main to actually crush the side branch stent. Okay. But whichever way you do it, I think you need to crush it optimally. And we actually did that at the Minneapolis, at the University of Minnesota Living Heart Lab, where we demonstrated, and I actually have pictures of that, not here, but where we demonstrated that you had to do that. Otherwise, you had a very incomplete crush and still an opening into the crush stent.
That might explain my difficulties later on I had during this case. Yeah. After that, so here's my first case. Now I'm placing a stent, left main LAD stent. We went with a 4.038. I know Resolute has bigger stents now, 5.0, but at that time I did not have 5.0 stents in my lab. So 4.038 was a larger size stent, and my plan was to just post dilate with a 5.0 balloon, which was the left main MLA based on IVIS. So that's just the stenting of the left main. So a couple of things happened after this thing. After this, I had a lot of trouble rewiring my crush stent, my side branch stent. It probably took, the most of the case was just rewiring into the crush stent. My usual choices of wire are choice PT, it's hydrophilic, it usually finds a strut. That did not go. When the choice PT does not go, the next option for me is usually a Miracle Brothers family, Miracle 3 or a Miracle 6. Unfortunately, that did not go. And I tried getting a microcatheter, a turnpike or something, that did not work. And finally, what worked for me was I pretty much lost all wire support except for the LAD. I lost my circ wire, and I took a 508 NC balloon and I did pot off the left main. And only after I did this was I able to get a wire across. I'll talk about that. I think that reiterates the statement you were making that I should have done the pots earlier.
At the beginning, yeah.
Yes. Any comments? Any?
Yeah, Arasi, it's Matthew. First of all, thank you so much for presenting this case, because it's important not to always present hole-in-ones, right? So this was great. And I think actually for me, this highlights a lot of the challenges with DK crush. In fact, I don't like the DK crush. Even with imaging guidance, it can be very challenging to really successfully do that first crush, as Vlad was talking about. So I mean, it's a great technique, great outcomes, but it takes a lot of OCD and really, even at one's doing one's best, often you cannot get that full crush, and rewiring can be so challenging and make what could be a very quick case with a tap into, an all-day affair.
That's true. So much for my go in and get out and less is more strategy, because I spent so much of time trying to rewire it. So then finally, I had to use a twin pass torque and get a Miracle 3 to get in. And then I was able to then serially dilate the circumflex stent with a 1.5 balloon and a 2.0 balloon. And then I was able to get the 2.5 30 into the circ and a 3.020 into the left main LAD stent. And here's my second kiss, by which time, you know, everyone is like super tired and exhausted, including the patient. We IVIS the LAD again. The stent was well expanded, well opposed. The parts, 5.0 parts worked well. The left main portion was well opposed too. And this is my final angiographic result.
So both Arasi and Vlad, we have to wrap this up to go on to the next case. Any final comments? Arasi, do you have a spider view of this?
This was, as I said, we were too tired. We were like, that's it, we're done. There's great flow. IVIS looks great. We are walking away from this before we do something worse to the patient. So
I think we do have a couple of Q&As. One was that perhaps provisional stenting, left main LAD would have been fine, as this did not fulfill definition criteria for two-stent strategy. And another one, personally, I have just done a provisional to the circ and stented the ramus. Much bigger vessel crush with 2.5 balloon is inadequate. And I think we've already gone through those. Any comments? Here's a question. Any comments on wiring into the side branch, proximal versus distal strut for DK crush?
Yeah, I think this was a very good example about how POT can facilitate rewiring side branch. But if you're still having difficulties, I think dual microcatheter can be of help, of course. Dual lumen catheters.
In terms of the question whether you rewire distal versus proximal in this case,
I will rewire in the mid, second after stenting main vessel.
Yeah,
I'll try to keep my wire proximal to mid, not distal.
Yeah, so with the DK crush, for sure, crossing the crushed stent, you don't want to go distal because you can go abluminal distally and then re-enter.
Exactly, exactly, yeah.
You can avulse your stent away from the distal aspect of the ostium. So I agree, proximal to mid is probably ideal.
All right, folks, we need to stop here.
Very good.
Thank you so much, both Arasi and Vlad, for an excellent case. So we can unshare, and Dawn can present our next case, and Matt Price will be discussing.
Great, thanks. All right, Dawn, let's close this out. Let's see what you've got for us today.
Okay, I'm off mute, and I think you see my screen. Yeah?
Yes.
All right, let me just get the people out of the way, except for you. Okay, so I'm gonna present a left main transradial case, which is unique because it's dealing with in-stent restenosis, which we have very little data on, so I'm very excited to hear what people have to say about this. Okay. Closures. I can skip the introduction. Everyone understands PCI anatomy. We rarely get an ostial or simple patient lesion. And we know the technique, studies have shown the technique you use is associated with outcome. This is a 71-year-old with a very complex coronary history. Cabbage over 10 years ago with edema and several veins which were all known to be occluded. He'd had multiple prior PCIs over the years, including the right coronary, mid left circ, a distal lima to the LAD, a left main into the circumflex, and subsequently a prox LAD, which was done at least a year and a half before. To those films because they were not at our institution. 45% he had chronic heart failure. His presentation was that of acute coronary syndrome with acute onset of substernal chest pressure, nausea, and vomiting. That he had some evidence of mild heart failure on exam. He had every risk factor. He also additional comorbidities, which are important, is he had paroxysmal AFib on anticoagulation. He was on dialysis and also had severe peripheral artery disease. On admission, you can see his EKG was quite ischemic. He had an initial troponin of 1, which I believe 3 to 6 hours later was up to 28, had a very high BNP and anemia. I'm just going to summarize the diagnostic cath. We were left radial. He had a right. He's got a patent lima to the LAD. The stent in the distal lima was patent. Stents in the native RCA. Actually, surprisingly, probably pretty normal at 16. He had a very complex Medina 111 with a bifurcation angle, probably a little bit less than 70 degrees, not heavily calcified, restenosis in both limbs. So by definition, a complex bifurcation. We've already spoke about the definition, how we can stratify left main lesions. We know stent techniques like culotte versus crush, which are particularly the culotte in angle, do not have similar outcomes. However, in Syntax trial, where there wasn't a ton of imaging performed, the type of technique was not associated with outcomes. But again, these are just some of the studies we talked about. So I'll stop, and Matt, you can choose which of these topics you want to discuss, or all of them, or we can continue to stop during the case.
I think what we'll do for the sake of time, I mean, great introduction. Basically, you've got a gentleman, insulin-dependent diabetes, a frequent flyer to the cath lab, who's already had bypass, who by that one shot he showed had basically distal left main, ostial LAD, ostial circumflex restenosis. With an EF that was, I think, about in the mid-50s, if I remember correctly.
45, yep.
45, so not awful, not perfect. Why don't you go through, I'm assuming you imaged and looked at things. I mean, stepping back here, he has 1 layer of stents in the left main LAD circ, or 2 layers?
We believe it's 1. I mean, I'm guessing from the detailed procedure notes, and again, without having the images, that there was a provisional approach probably to an ostial circumflex where the back into the left main without addressing the LAD at all, without any intervention. But then an ostial LAD lesion was then later treated with potentially, maybe a tap, maybe dual balloons. I don't really know. So I was going to image to figure that out. How many layers?
I think just basic principles here is we want to understand why there's restenosis.
Exactly.
And 2 is, I think, trying to minimize more metal if you can, whatever technique that might be. And 3rd is thinking long-term, are we thinking brachytherapy or something like that? But I'll let Danya, why don't you proceed for the sake of time?
Yeah, and of course, again, some of the things may be based on the imaging. So I just don't want to spend time on the sheath, but just to emphasize for people who don't do a lot of radial, that you can certainly use a 7-foot French, a 6 French, or 7 French slender to get larger guides. In this case, we wanted a 7 French guide, so we used a 7 slender in the radial, which was fine. You can also use sheathless guides, which we carry in our lab, which can give you a much larger inner lumen, 7.5 for a very small outer diameter, less than 6 French. You can also use the railway system to do sheathless guides, either 6 or 7 as well. We chose a 7 French XBLED4. We didn't feel there was an indication for hemodynamic support. There's a patent Lima, there's a patent right coronary, the EDP is fine, the blood pressure was 140 to 150. And the other option would be if you felt there was a need for MCS, if it's complex like atherectomy, et cetera, with long ischemic times, but we didn't feel like that was going to be the case. I was concerned, we don't have drug-eluting balloon. I do not have brachytherapy available. And so again, aside from pure stent under expansion, the plan was going to be 2 stents if this was aggressive restenosis. These stents are over a year old. So the stenoses were so severe that both dilated and then OCT was performed. I'm just going to let them run, and then I've stopped afterwards to give some key points about the reasons for stent failure here. Okay, so in the LED, you can see that the distal stent reference is here about 377. The stent's well expanded with no ISR. At the Ostial, at the Prox LED, there is a combination of stent under expansion. The stent reference to expansion index here is probably on the order of 70 to 80%. But there is aggressive intimal tissue, and you can see some balloon dissections resulting from the balloon angioplasty. Here you can see at the bifurcation that there does not appear to be much stent overlap. You see there around like 8, 9 o'clock, there appears to be 2 layers, but for the most part, it appears single layer with the stents. Again, it was stented originally from the circumference into the left main, but there's no gaps and there's very little stent overlap. Here in the circumflex, you see there is distal reference has an eccentric calcified plaque. Richard had brought that up earlier, and you'll see how that affected the case. You have more aggressive intimal hyperplasia here in the circumflex with much less stent under expansion. The stent is actually quite well expanded. Here again, you see good ostial stent configuration and the left main diameter about 4. So I don't know if that helps anybody in terms of the strategy they want to take.
Great, Don. I'm gonna sort of ask our panels. Beautiful imaging. Vlad, what do you think? What's your strategy here? What are your? I guess at first, what are your goals, and then how are you going to achieve them? You're on mute.
I am indeed. It's a tough situation in terms of this being ISR. I think the main probably has to be restented. I do have access to drug-eluting balloons, so I would try to see if I could optimize this with a balloon in the ostium of the circumflex. And if I could, then I would treat it with a drug-eluting balloon. If not, you may have to restent it. In this case, I guess you could still do this as a DK crush, or you could do it as a provisional technique. It sounds like it was probably a T-stent first time around, right? Because you don't have much overlap. And in spite of that fact, in the ostium, do we have a sense, can you show me which is it C, that's the ostium of the circumflex, or do we have the circumflex here? Dawn?
Yes, C is at the ostium.
So is it clear that the stent is appropriately sized for the ostium of the circumflex? I can't see it that.
Yeah, I think it measured a little above 3.
Okay.
There are some markers here you can kind of see, but yes.
Yeah.
So, I mean, if you look on the long view, it gives you a better sense. I mean, obviously there is still stenosis there, so it's hard to exactly see the stent. The stent is a little bit better expanded, but it is still, there is slight under expansion at both ostia.
Yeah, so I mean, that gives you a chance if you're able to dilate this with the appropriate size balloons, kissing balloon, before you do anything else. That will give you a big clue as to whether you have a chance with the ostium of the circumflex with the drug-eluting balloon. So that's how I would start. If you're able to achieve that, and I've had success with using drug-eluting balloons in the ostium of circumflex in this case, in this kind of a situation. So I think that that is a reasonable approach. If you have persistent recoil under expansion, if you can't get a good lumen, then you might actually consider doing a really good optimal DK crush in this situation.
Yeah, for the sake of time, Vlad, we're gonna move on. I am a little concerned about doing any sort of crush, even DK crush stenting in the distal left main here. If you don't get full expansion of that circumflex, the ostial circumflex, I agree, doesn't look so bad. Maybe you could just actually do a T almost and just focus on the MLA section of the circ. But Don, let's see what you did.
All right, you'll see what my interesting choice was. But I would also comment that, yeah, if I had drug-eluting balloon, also potentially running a 1.4 laser catheter to get rid of some of the tissue. Now, I probably wouldn't do that if I wasn't going to restent or have access to a drug-eluting balloon, because I think it could cause more injury. But you know, again, if you're stent layering, laser ablation of the ISR may come in handy. The room I was in was not, we didn't have the right plug for the laser machine. So I didn't have that option. Now we do. But I would keep that also on the table for stent under expansion. But again, in this case, there wasn't much calcification. I thought we would, unless we were at the maximal limits of the stents that were chosen before in terms of their expansion capability, I thought we could probably get stent expansion. So I actually was trying to minimize the amount of metal without access to DEB or brachytherapy, and the degree of restenosis, and the fact that I was fairly certain that the ostial circumflex was likely ballooned a year ago when the LAD was placed, which was about a year or so after the circumflex stent was placed, that the stent is a couple years old. And I just did simultaneous bifurcation stenting, almost like a T-stent, and having the outline of the prior stent to pretty much use that to avoid crushing too much, if any, of the circumflex stent. So that was the strategy I picked, and that's why I'm here to see what other people would do. But again, so the circumflex was deployed. It's a little oversized. So if you remember, the OCT lumen by that calcific plaque was about 2.8. Again, that's not the media, so I figured the vessel was at least 3.0, but the left main here is so large, I went with a 3.5 and also a 4.0 in the LAD. And then I didn't show all the steps, but pot, kissing balloon, and then you'll see I'm taking an OCT. So every time you take an angiogram, you do an OCT to minimize your contrast. And you can see, I'll just let this run again, that we did run up with the problem most people were concerned about, which is that the ostia of both vessels, but in particular the LAD, is underexpanded here. And what we also saw by OCT imaging is that we had a small intramural hematoma when the stent landed next to that eccentric calcification, because the stent was also oversized. And then we had definite underexpansion. Our cross-sectional area of that ostial LAD was only 6.8, and you know the reference is about 12, so it's woefully inadequate. So I'm sure most people would go back and fix it up, and that's what we did. So one, we did use a 3.012 circumflex to connect that. There was just unfortunately a little small gap between the old circumflex stent and the new stent, and that was covered. Then took a very NC balloon all the way up to 20 atmospheres in the ostia, and then did really large, high atmosphere, 1-to-1 size NC balloons to finalize this. And then you can see we did, I'm only showing the LAD here out of interest of a lot of imaging, but here on the side on the left is our more distal LAD with 2 layers of stent. And you can see actually the stent compression, the intimal hyperplasia is very, very well compressed. There are some little areas where you see that tissue, some prolapse and not full compression, but we were able to get the MLA here over 9. And you see the ostial conformation looks quite good. And here's our left main. And when you look at the pullback, when you look down here longitudinally, you'll see that the result looks quite good. So this is our final angiogram. And again, while I was doing this case, I was, trying to think, it's just, we have an absence of data on what stent strategy, but I thought minimizing that, I agree that in the future, should we have drug-eluting balloons in the United States, it was such a short lesion that potentially at least giving it a go. And if they come back, then adding that extra stent could be an option.
Hey, Don, great. I have a couple of questions for the panel. So anything, you go back one. You showed very nicely after you put in that stent, particularly in the LED, you still had some stent under expansion. What about lesion preparation? I mean, what were your thoughts? You just used an NC. Are there other things people would have done beyond just say laser, just a standard laser with saline for the neointimal hyperplasia? We're talking about stent under expansion here. So anybody in the panel would have maybe done things differently, or maybe done what Don did in terms of trying to fully expand the stent before you put in your new stent? Any thoughts?
Matt, one of the, I do like the idea of laser atherectomy with these kind of in-stent restenosis that really, gives some advantage in terms of the expansion, because there may be some underlying calcified tissue below the stent. The other option would be to consider doing something like an angiosculpt or a chocolate balloon.
Right.
And that's what, we would have done probably in this case. You may also consider a cutting balloon to try to create some fissures. On the earlier OCT image, I thought that there was some paucity of stent struts at the very, very ostium of the circumflex, and maybe because of the angulation of the stent, there may have been some geographic miss of the drug, which may have led to this phenomena.
Raj, let me go back.
Otherwise, the result looks good.
Raj, let me look back at some of your comments, Raj. So first, I agree, chocolate balloon, high pressure chocolate balloon or angiosculpt inflation. When you talked about laser, and we're talking about stent under expansion to get behind the struts, are you talking about laser with contrast in the situation? Or
No. So I think that with photoablation, you don't only, it's not like rotational atherectomy where, you only affect the surface. For example, we take a 6 millimeter femoral artery and we put in a 2.2 millimeter laser in it. And it leads to a fairly large luminal gain in those vessels because of deeper penetration of those photo energy bubbles. So I think that, at times we would use contrast if the lesion was heavily calcified and we are not able to expand it, or we are not able to get a rotablator through it. But in this case, I don't think that technique is necessary. I think it's just 1.4 millimeter laser, just like Don has suggested, would be adequate at least for the LAD.
Great. We do a lot of laser balm, we call it, with contrast for stent under expansion. Really, and then you go back with an NC balloon. Impressive results. But in this case, proximal LED left main, you could talk about a lot of ischemia due to your vessels. You get those bubbles, block up the distal vasculature. So not a great idea, I think, for the left main. So Don,
I tend to reserve that. I always try the saline first.
Yeah.
Before I go for the contrast.
What about shockwave, Matt or Richard? What are your comments?
Yeah, I didn't want to mention that again. I've been dilly-dally. I've been sort of dipping my toes into using shockwave off-label, of course, in the United States for these types of things, for stent under expansion. And sometimes it works, sometimes it doesn't. Richard, what do you think?
So I think that the most important thing when you have in-stent restenosis here with tissue protrusion, you need to get the largest lumen possible. You're going to have restenosis. And I'm not sure just a drug-eluting balloon would do that for you with that residual tissue. What I would do here, first of all, I would size my laser bigger. If it was a 3.5 vessel, I would use a 1.7 laser and in the circumflex I'm talking about. And certainly consider shockwave to break up any calcium behind the stent. I'm looking forward to doing that. But to me, I would try to get the largest possible lumen I could. And I go to 28 or 30 atmospheres. And then document that my MSA is as good as it could be.
Don, how extensive was the calcium in terms of the circumference?
Again, I could be underestimating it because of the stent, but predominantly it was And despite being a dialysis patient, you saw kind of eccentric in the circumflex. There was one area of the stented segment that was about 90, but it really looked just like typical ISR, but not calcific. These stents were not encased in calcium by any means, or definitely a different strategy would have been necessary.
Yes, I don't think shockwave would have worked here.
I think Richard's point is a great one, is that when dealing with ISR, before you're going to put in another layer of stent, make sure you've maximized the lumen, make sure you do not have stent under expansion, be it with whatever modality you want to use. Don, this is a great result here. You want to go forward for the sake of time to the next?
Yeah. I think the angiosculpt is a good idea, or just I wish we had super non-compliant balloons, which I know we should get those. But left main bifurcation cases don't shy away from the radial, because again, backup isn't usually an issue in support. If you need MCS, and I'm using Impella, I almost always try single access now to just try to minimize bleeding. Majority of cases, everyone knows you can do the DK crush in a 6. 7 French just allows you a little more movement of the equipment, especially in very, very large vessels, or if you want to do simultaneous 2 stents or trifurcation balloons. And using your imaging, I think, is a must in all left main to improve outcomes, but in particular in stent failure, it is the only way to treat stent failure. So thank you very much for the comments on the case.
Terrific case, Don. Yeah, applause. Any panelists, any further comments about Don's case? That recurrent ISR, the distal left main, always a challenge, and especially if the patient doesn't have bypass as an option. Perwaiz, any thoughts on that case?
No, I totally agree with what everyone said. I think it's important. We don't really have drug-eluting balloons on the market, and so even if you were trying to use that as a strategy, it'd be off-label in the United States. And so what we do use, Matt, what you and I both use, is brachytherapy. And so we use brachytherapy pretty consistently, and exactly what Don did and exactly what Rich said is the key. Your brachytherapy, or probably even your DCB or DEB success, is probably going to be predicated on the fact that you got the best luminal gain with the stents that's there. So if you do not optimize those stents, I don't care what you use, it's not going to work, including new stents.
Yeah, including brachytherapy. So really what we've moved to now, we do a lot of brachytherapy at Scripps Clinic, and those we're usually doing either shockwave now or laser with contrast, depending on the amount of jeopardized myocardium, to really get the best result we can before brachytherapy. Azeem.
Yeah, so about DCBs, I used a lot when I worked in Europe. And the same holds true. I mean, we've published data showing that unless you get a good angiographic result with your lesion preparation, there's no point opening the drug-coated balloon. You're not going to get a crappy result. So yeah, we probably would have used cutting balloons. We're using high-pressure cutting balloons a lot with really good outcomes. So we would have done that.
What do you mean by high-pressure cutting balloon? Because
so we'd slightly undersize the cutting balloon and go to 22 atmospheres with a Wolverine.
Okay, so that's much higher than the rated burst pressure.
Yeah, and we've not had issues with that. As long as you slightly undersize when you're going in native vessels, but at that high pressure, you get an effect beyond the cutting, which is a very non-compliant balloon. In Europe, there's this balloon called the OPN balloon that goes to 40 atmospheres, which I'd love to have.
How high does it go, Azeem?
40.
40.
40.
Oh, we need that. We need that.
Special inflator for that.
That is a good balloon.
So one of these valve indifferers, we used in front of valve. We use that. I mean, in Europe, I use a lot of shockwave. I think it works well with underexpanded stents. Peripheral one, but it's a nightmare. It's the 40 millimeter balloon, a crappy profile. It's over the wire. You got to get a grand slam down, and you can not deliver it anywhere but a straight proximal vessel. And I've tried. I mean, I this week I actually tried. I put an 8 French sheath, 8 French guide with a 7 French guide liner to try and get this bloody thing into the coronary artery, and it wouldn't.
Shockwave over the wire.
So we'll have to wait for the coronary one to come.
Vlad, the peripheral shockwave.
Okay. So that's all you have access to.
That's all we have.
Only 40 millimeters.
Yeah,
We
have
below the knee balloon, very stiff, 40 millimeters long.
Richard and I will get a little shout out that the Shockwave coronary trial results will be presented at TCT. So we're excited to see how that looks.
Yeah.
One caution about cutting balloon is the side branches. If you put in a circ side branch where it's within stents and all, it can get stuck. Okay, so so just be careful about that. Then the other thing is this patient is renal failure. You're putting second layer of stents. What is the chance of restenosis? I'm going to tell you that it's going to be very high. He's got renal failure. The milieu is not good. So Don, what are your comments about renal failure in this patient?
Yeah, I mean, again, I didn't really have an option, but in the future, I would call Kevin Croce to do brachytherapy. He's right down the street from me. He's not here today, but
Kevin
we work together.
Join us. Yeah. Well, I think, are there any Q&A questions? Matt, do you need to answer?
Yeah, there's someone asked, what are the scoring balloons? So I'm typing the response. If I can, I don't really know how to send it, unfortunately.
But just relay your message.
Yeah. So the question is, what are scoring balloons? What are the scoring balloons? So scoring balloons traditionally was called force focus angioplasty, where you go to low pressure and you use blades to score the plaque. Nowadays, we're going to high pressure with these balloons. That would be the Wolverine, which is the newest generation cutting balloon by Boston Scientific. There's the chocolate balloon, which has basically a nitinol cage, which creates pillows. And then finally, there's the Angiosculpt, which has a double helix of nitinol, which acts in the scoring fashion. And the Angiosculpt and chocolate go to high pressure. Wolverine, as I've learned from Azeem today, can go to high pressure. I would say Tanveer's comment's an important one. I've had like a chocolate balloon get stuck in a side branch of stents in a bifurcation stent situation because it does not, it can get very winged and get caught. So be careful in side branches. Tanveer, I'm gonna turn it over to you. First of all, thank you and congratulations on this first live web stream for the ABC, and thank you for your leadership.
Thank you so much. Thanks so much. We'll do this regularly, but probably just for an hour. Discuss probably 2 cases would be good to discuss. We'll do it in a monthly fashion. And final comments from our esteemed panel. Any comments before we cut off the transmissions? Starting with whoever wants to go first. Okay, Matt has said what he has to say. Don, and then Vlad and Azeem.
Yeah, no, I think this is a great forum to learn from each other. And that again, bifurcation intervention is a fluid intervention in my mind. It's constantly changing, and so I'm looking forward to feedback, and maybe we all become more consistent over time.
Perwaiz is next. Perwaiz, do you have any comments?
I totally agree. Thank you very much for the opportunity to participate, and I think this is a great, endeavor for us in the United States here. I think we can all learn from each other. I think, very important to try to optimize our results as best as possible, learn from each other, and try to give our patients the best chance they can. So looking forward to this, and thanks again.
Richard?
Well, every day I use imaging, I learn more and more, and being with this panel and learning how you guys and all you work and do things differently than I do, I'm going to take those techniques and try them and try to optimize it. So I look forward to future sessions so I could learn more and do a better job.
Thank you very much. Arasi, are you still there? All right. Vlad?
Yeah, no, it's great. Thank you for allowing me to be part of it. And it's a great discussion, great team, I would say. Wonderful case-based. I think this is the way to go. Case-based presentations. I think we all learn from this, and hopefully I'm sure this was useful for everyone.
Absolutely.
Final comments from Raj.
Well, thank you very much, everyone, for taking your valuable time on Saturday. It was an amazing start today. You have a great attendance on Zoom. On a secondary platform, you had over 1,000 attendees from foreign countries. So very strong start. And I wish everyone a wonderful weekend, and looking forward to seeing you again in near future.
Let me congratulate you for this webinar. It was really very, very educational. Discussion was great. I think we all have learned something today. Thank you. Thank you for the invitation.
Thanks, Imad. Thanks, Imad, very much.
Thank you, Mia, and thank you, Alyssa, for putting this on. We will talk to everyone about, get a schedule of people who, we will not ask everybody to do this every time, but ask the schedule of people to do like 2 of you each time every month and do these cases. And we'll put a schedule together with the help of C3 Academy. But thank you, Raj, for
allow the attendees also to submit cases that they could present.
Oh yeah, that's the goal. We're going to allow
great.
everybody to people who want to present cases and choose those of educational value, invite them to the webinar. I think that will be an open forum, and I think that's where we'll go.
I think that effort has already started, right, Tanveer? You know,
we're working on it.
That we are already collecting cases.
We're going to
that will be great. That will be great.
And we'll send a calendar, and people can put their name of which months they want to do, and we'll take it from there. Kevin could not be here, still working on a case, but thank you everyone for a real good start to this meeting. Thank you very much, and thank you.
Have a nice day, all.
Thank you.
Bye.
Everybody stay safe.
Thank you. Bye.